Walking through the implant department the other day, saw a case that I thought was interesting. It's an impression that came in from a doctor, and the impression looks okay. It appears to be a two-step impression. You'll notice that the two layers of material don't appear to be blended together real well, as they typically are in a simultaneous impression where we see a really close blending of the two where it's almost impossible to tell the two apart. It does look like they set at slightly different times and they're sitting on top of each other, and it looks like they could be peeled apart just slightly. And again, we don't see the blue material coming all the way across. We always get a little bit worried that we might have a double impression when we don't see both layers of materials represented all the way across the arch on both of them. We really like to see that all the way from the posterior area on this side over to the posterior area on the other side. But it's a closed tray impression, as we can see when we flip it over, and the doctor did use closed tray coping, so that part was nice, as we'll see when we look at the model here. So looks like we're going to be able to work with this. Probably not perfect, but certainly definitely a lot better than some of the impressions that we receive. And so as we take a look at the impression itself, definitely looks like we're going to be able to work with this. The doctors requested a PFM bridge from 19 over to 26, and really the issue with this case as we come in and look at this is that we did receive an opposing model, and we've got that as well. What we don't have with this case is any sort of a bite registration. And that's going to make this very difficult to deal with, as you can well imagine, because we've only got 4 remaining natural teeth here on the lower arch. We do have the entire opposing arch, but of course with no teeth over on this side, it's anyone's guess as to where these teeth are going to go. What we do happen to have is a study model before these teeth were extracted and the implants were placed. And if we try to hand articulate these study models from before and put these together, it looks to be the most natural position for these teeth is that the patient actually comes together in a class 3 relationship. And that's where the wear facets, and that's where everything really seems to line up. You can see we've made a couple marks here with the class 3 cuspid and molar relationship. And we actually called the doctor and confirmed this, that the patient is in fact a class 3, a natural class 3, and that this is where the patient bites together. But even knowing this relationship, if we try to hand articulate it this way, it's pretty difficult. We can lock it in over on this side and say, okay, that's where it is, but how in the world are we going to get the vertical over on this side? It's just impossible to guess, try to get this spatial relationship and guess where this is going to be. It's pretty impossible. Now, sometimes what I've seen the technicians do, say in the crown and bridge department, for example, is jump the bite. And so what they'll do is they'll take a study model like this and they'll hand articulate it. So if we know, for example, that this guy's a class 3 and we feel like, okay, this is actually a pretty good representation of where this patient belongs. Sometimes we'll even send a photograph back to the doctor, and have them verify it. We'll take impression putty and we can push it against the lingual aspect, not so much of the teeth, because usually those have been prepared, and we'll push it against the palate and the teeth if they're remaining, say, for example, on the upper, and against the vestibule, the lingual vestibule on the lower. And so we'll just take impression putty and really push it against the back of there and make an index, if you will, of any remaining teeth and, say, the upper palate and then the lower vestibule, and try to really get something where we can take that and then take the lower model, in this case where the implants are, and then hold it in and push that together. But you can see from the impression, because it was really lacking in the area of the lower vestibule, that we just don't really have enough anatomical information here to be able to even jump the bite. You know, I'm not saying that jumping the bite like that is really a great technique. It's still kind of hacky in a sense. It'll do in a pinch, you know, if you don't have the bite registration and the patient lives 100 miles away and it'd be really difficult to get them in, or if we've lost the vertical completely and we don't think we can get it. You know, using that putty on the lingual surfaces of the study models will at least get us close, and if the doctor is willing to spend some time grinding in the occlusion and is okay with us guessing. But here, you can see that on the study model, well, we've got some great information there. That appears to have nice information in the vestibule where we could push the putty against there and get some information here as well. But here we really don't have much information there, so we're going to be guessing. So really what we need to do here is a bite block, but again, we don't have a lot of information here. We can't wrap that very far down. And even in the buccal vestibule, we don't go very deep and we don't have a lot of room, so we're really going to need to keep it confined to the top of the alveolar ridge. And so we're going to need to put a couple temporary abutments in here to have it sit down on the top for this wax rim. The doctor said he didn't want to pay for those, but doctor, you're just going to have to bite the bullet on this one and pay for those. I think they're like $6 each, so come on. You're going to need to man up, add $12 to your fee, or just eat the difference, because we're going to need a wax rim that's going to sit down and engage into a couple of these, just two, maybe one here and one here, so it's going to sit on the top and not wiggle back and forth. And the other thing about these wax rims, base plate wax is a notoriously inaccurate material. The patient can bite into it and squish into it, but it distorts really easily. It could be hot in the back of a FedEx truck as well. So I'm going to suggest that you cut it back and then really put some cross hatches in the top with a hot Bard Parker knife or a lab knife, and then squirt some bite registration material onto the top of that and have the patient close into that. Much more stable. And even if the bite registration material comes off the wax rim, it'll fit back in because you have those little cross hatches on the top of it. And that's way more stable. When the patient bites into that wax rim without the bite registration material, it's just kind of mushy. And then when we go to take the opposing teeth and push it into the wax, it distorts the wax and pushes it around. And it's never a very stable bite. So it's fine to use wax for the bottom part of the rim, but when the opposing teeth come in contact with it, it works much better if we have actual bite registration material for the portion that comes in contact with the opposing teeth. So all's not lost on this case, but we definitely want to use a couple temporary abutments here to hold the wax rim in place, and then use some bite registration material for the patient to actually bite into. And that being done, we get an accurate bite from that, we should be able to have a case that ends up being very successful for the doctor and patient alike.